Welcome back to the Oncology Journal Club podcast, brought to you by the Oncology Network. Are you ready for some ESMO Bingo? Yes, it's that time of year again. I'm your producer, Rachel Babin, and I am once again joined by our Journal Club Dream Team, Professor Craig Underhill, Dr. Kate Clarke, and Professor Christopher Jackson. This is part 1 of our ESMO Special, where the team cover ovarian, breast, melanoma and GI cancers. Expect the usual nuanced analysis and a few naughty jokes along the way. For more information about the Oncology Network, including links to the abstracts discussed, head over to oncologynetwork.com.au. Thanks for tuning in. Let's get started.
G'day, or should I say guten Tag. Welcome to the OJC post-ESMO Berlin 2025. G'day, Dr. Clarke. How are you?
G'day, Craig. Very well, thank you. Feeling a whole lot better now that the wind has settled.
Any more sausage jokes to be expected? Talking about Berlin and bratwurst?
Oh, look, you've left that door wide open, so you know how much I love a sausage. And there is something obvious I could say, but those of you who know and listen to this podcast will know the 2 words that I want to say next, but I'm being too well behaved. So, Professor Jackson, how are you this afternoon?
Kia ora. We had some really good listener feedback from the last episode, actually, Kate. Keep up the good work, really. See if you can slip in a sausage during the course of the discussion today, seeing as we're referencing Berlin.
I'd rather a sausage than radiation. There you go. Yeah.
Oh dear. Just leave that, park that little joke.
Quite funny watching Craig blush on a podcast. We need to put that online somehow.
All right, so let's get into it. So it was a pretty big ESMO. Kate, are you happy to go first? Because I think it was sort of breast moment in the sunshine. There was probably more hype about the breast abstracts and other tumour types at this meeting.
Yeah, I'm going to step sideways briefly and talk about one ovarian abstract. But I think increasingly ESMO is the place to be. It's a very long way for us poor Aotearoans to go, but does seem to be where a lot of the hard-hitting data is coming. So the first I want to speak about is Keynote B96, which was presented by Nicoletta Colombo. This is a trial in women who have ovarian cancer who are no longer responding to platinum. So those of you who look after these women, this is a dire situation, and although we have some systemic therapies, we're not expecting a lot out of many of them. So the addition of pembrolizumab to paclitaxel plus and minus bevacizumab is what we're looking at. So the difference being the pembrolizumab. The overall survival was improved statistically significantly in those women with PD-L1 of CPS of greater than 1 from 14 months to 18.2 months, so 4.2 months delta, and a trend in the overall population from 14 months to 17.7 months, but didn't quite meet their pre-specified statistical criteria. I don't have in front of me, because I only have an abstract, the proportions of PD-L1 positivity in platinum-resistant ovarian cancer. So I think that's something that we will want to look at. So interestingly, first time that anybody has been able to prove a role for IO in immuno-oncology, in ovarian malignancy. So this is interesting. So Keynote B96, the only gynae thing I'm going to talk about today.
So Kate, it's the second time, because we talked about it on the last increasingly infamous podcast about Nivo and Ipi combination in advanced ovarian and endometrial clear cell carcinoma study that Oliver Klein led in Australia with the clear cell carcinomas showing, it was a phase 2 study, but showing really quite impressive activity in those rare subtypes.
In a rare subtype. Apologies. Yes. In my head, I'm thinking about the stock standard non-clear cell ovarian, so epithelial ovarian. So yes, you're right. So in that clear cell, yes, there was and that's exciting because that's a not easy to treat cancer at all. This is in quote unquote stock standard ovarian cancers that are no longer responding to platinum. So that's interesting. Small delta, but definitely statistically significant.
So that's great. 2 studies showing, one, of course, a phase 2, and probably won't be able to do a phase 3. And interestingly, in Australia, the PBS has approved, PBAC has approved to list on the PBS the combination of Ipi-Nivo in rare cancers. So a tumour agnostic indication. So that's pretty exciting. And so I think it'll be difficult in that rare subtype to do a phase 3 study, but there's 2 studies now showing some activity in ovarian cancer. So,
and that Ipi-Nivo, the PBS, where is the cutoff for rare tumours? What do you call a rare tumour?
Well, it's actually tumour agnostic. So they think that the role will be mostly in those rare tumours, but basically it's an indication for where clinicians and patients feel that would be an option in their best interest.
So is that carte blanche now, Craig?
Yeah, pretty much.
There must be some kind of massive cost
there's a
sharing deal which has gone on with that. I mean, otherwise the cost implications of that are huge. I mean, Ipi for 4 doses at 1 milligram per kilogram, something like $32,000, something like that. If it's at full dose, you're looking at more like, what's $120,000 New Zealand. So it's a lot of money for that for unproven benefit.
So there's a very long wording to the listing, but it's basically covering advanced or metastatic cancers where there's evidence to support efficacy and a positive benefit to risk balance, and they're estimating it with about 5,000 patients annually. And they've also removed the once-in-a-lifetime limitation for those medicines as well. So patients, if they've had checkpoint inhibitor in the adjuvant setting and then subsequently relapse, they can be re-challenged, which in the past was difficult to do. So anyway, we can talk about that on our next regular episode maybe, because it is an interesting area. But I just thought I'd throw that in as well. So, for those rare cancers now, there is a pathway to access the checkpoint inhibitors if it's felt the balances in probability of benefits there.
Sadly, only in very far west of New Zealand. Look, we'll get it. Motorboat.
Hang on. What? Far west New Zealand?
Far west New Zealand. We're going to motorboat through the breasts now. So we've got adjuvant CDK4/6. So 2 big trials, long-term outcome. Not really long-term in ER-positive breast cancer, but this is where we are. So Monarch E, just to remind people, 2 years of 150 milligrams BD of abemaciclib alongside people's hormones, a higher risk population than the other trial we'll talk about, no node-negative women, for example. Then Natalie, which were 5-year outcomes from ribociclib given adjuvantly at a dose reduction compared with the metastatic setting, a lower risk population. Very similar outcomes. Monarch E, 7-year follow-up, an OS delta of 1 and a bit %, and that did reach statistical significance. Natalie, a 5-year overall survival difference of 1.6%, but hasn't met statistical significance yet. Hazard ratios for all of the other things are the same, about 3.7. Number needed to treat.
That's why I'm playing a Bing. I'm playing post ESMO Bingo. I've got a bingo card. And so you just met one of the parameters.
So the number needed to treat for several $100,000 worth of treatment per person is in the 80s, in the 8 zeros. So yeah, we'll get Ipi-Nivo for everybody before we get adjuvant CDK4/6. So that's that one. Thoughts? Will you be prescribing 3 years of abemaciclib for? No, Chris is pulling a face. Yeah, and it's a taste
interesting in breast cancer field seems to often embrace small incremental gains compared to other tumours. That's just historically that's been the case. But anyway,
I think it's interesting because they're very biomarker driven to a point, but not beyond that. Because you'd think there will be, if there is a benefit, there will be a group. Where's my Bing, Craig? That is biomarker driven. We just don't have the right biomarker yet. Then I want to quickly switch to HER2 positive breast cancer. So Destiny Breast 05. So this is comparing trastuzumab deruxtecan compared with trastuzumab emtansine. So the 2 anti-HER2 monoclonal antibody drug conjugates. Very similar trial to Catherine. So reminding yourself, people who have had neoadjuvant chemotherapy with an anti-HER2 agent, or at least one anti-HER2 agent, who had residual disease at time of surgery, so it's not a PCR, were randomized between trastuzumab deruxtecan and trastuzumab emtansine. And there is a hazard ratio for disease-free survival of 0.47 in favor of the trastuzumab deruxtecan. I'll be very interested to see how long it takes or if they're able to prove an OS, because remember, it took us about 7 years to get the OS out of Catherine. So, and the residual patient numbers are getting very, very small indeed as we're improving things. Destiny Breast 11.
Hang on, Kate. Was there any new safety signals?
Yeah, actually. No, well, yes and no. So I don't know how you guys feel about this, but in a post-neoadjuvant treatment where the overall survivals are in the 85 to 90%, how do you feel about 10% of people having interstitial lung disease, 2 of whom is grade 5?
Yeah. So is this the adjuvant trial? Is this the adjuvant trial, Kate?
This is adjuvant, post-neoadjuvant. Yeah.
Okay.
Yeah.
So I think when you were talking about long-term disabling toxicity or death in an adjuvant study, you have to have a very high threshold of benefit to warrant that, because adjuvant patients, by and large, are cured. And so you are exposing cured patients to potential lifelong disability or death, which is something we'll come back to in the OS data for melanoma later. But it's a very high threshold, and the drugs are very toxic in that population.
So, so grade 0, no tox. Yeah, grade 5, dead. So only 0.5% of patients is how it was worded. That's a worry if you're one of the 0.5%, I imagine. In the conclusion, safety of TDX2 was generally manageable with no new safety signals. Yeah. Right, Destiny Breast 11. So this trial pisses me off. And I know I've been lauded and told off for swearing, but ridiculously. So this is a neoadjuvant trial. So what they were doing was comparing their standard of care. What they called standard of care was dose stents AC followed by paclitaxel with trastuzumab and pertuzumab. That's what they call their standard of care. Now that involves a 10 to 12 week delay to your anti-HER2 therapy. So that makes me grumpy. Anyway, so then they had 2 arms, one of which they won't tell us what their outcomes were, and that was 8 cycles of trastuzumab deruxtecan. And then the second arm, which they've actually published the comparison, is 4 cycles of trastuzumab deruxtecan with trastuzumab and paclitaxel, followed by trastuzumab, paclitaxel, and paclitaxel on a reasonable schedule. So they've just sort of made it unbelievably complicated for no other reason than they can. And then there is a small difference in PCR, but not a huge delta. Normally we see if you're going to change things, it's got to be by less than 10%. At the moment, we don't have any other useful endpoints. Conveniently, the grade 5 toxicity rate is the same in both very complicated arms. And because you avoid the anthracycline, your left ventricular dysfunction is lower. But interestingly, they're claiming their drug-related pneumonitis is the same, but I think that was probably grade. I think they haven't graded that. So if you grade it 0 to 5, paclitaxel will also give you pneumonitis, but not as nasty. So I think this trial is bullshit. It's my short answer, because the standard of care is not standard of care, and there's other things, and they haven't reported their third arm, which they randomise people to. So yeah, bullshit. Right. And I know the breast team will be all upset with me, but I'm sorry, bullshit. I'm also really nervous about us using increasingly toxic and quote-unquote efficacious drugs in the early setting, and that will get approved tomorrow, right, in many jurisdictions, and we don't have an OS, and we don't know what the sensible sequence of anti-HER2 therapies are. And for those of us who work in both the breast and the colon world, we keep learning stuff we didn't know we knew. Neoadjuvant or perioperative cetuximab doesn't work. Perioperative chemotherapy, metachronous metastasectomy probably kills people, or at least lowers the chance of survival for those that are going to relapse. We don't know what we don't know. So that's what that trial's bullshit.
Kate, are you saying longer follow-ups needed?
I am saying longer follow-up is needed. Yep.
Look, I think...
But it's breast, so OS will be a secondary endpoint if mentioned at all.
It should never be a secondary endpoint in the adjuvant
No, of course
system.
It's not.
It's the only endpoint that matters in adjuvant studies, because also it's a question of sequencing. It's advantageous in advanced disease. So really you're talking about whether you use it earlier or whether you use it later. So OS is the only thing that matters. And then also ensuring that they have adequate access to post-protocol therapy with that as well. So if they didn't receive it adjuvantly and they went on and relapsed, they did get it in that advanced disease setting, which is often not the case. And so by artificially withholding access to a later line of therapy, you can inflate your chance of survival, which is, again, a trick, unfortunately, we see too often.
Look, I think short of them publishing the full data and me being able to see that, it's impossible to tell because the follow-up for this for the data is 2024. Trastuzumab deruxtecan in the metastatic setting is relatively new all over the world. I don't know when Europe got access to it. So the first women enrolled in this trial may not have had access in the metastatic setting unless it was mandated in the trial. So, you will hear us. I feel like Craig needs another bingo card, which is stuff that Chris and Kate will wink on about. But one of them is, OS is the only thing that matters in adjuvant trials. Metastatic setting, OS and quality of life are probably the only things that really matter in trials. And you've got to have a now or later, otherwise you're cheating. Now versus never is not a fair trial. Yeah. Right, quickly.
It's a fair test in metastatic, Kate, but it's not a fair test in adjuvant.
Yeah. So now we're quickly going to romp into the unpronounceables. So there are two
Yes.
monoclonal.
These are my two new favourite molecules
Oh,
at the
goodness.
moment.
Right. So just now I can pronounce sacituzumab govitecan, but I want to talk about datopotamab deruxtecan. There you go as well. ESMO did a good thing. They put all of the very similar trials together, which I quite like. So LBA20 and LBA21. So Ascent-03 presented by Javier Cortez, very charming man from Barcelona. And so sacituzumab govitecan in women who, for whatever reason, can't have pembrolizumab, understanding that we have data to show that sacituzumab govitecan plus pembrolizumab is better, quote unquote, than chemotherapy plus pembrolizumab. So they took women who either were PD-L1 negative or had pembrolizumab in the neoadjuvant setting or had some contraindication and compared sacituzumab govitecan on its own with chemotherapy, dealer's choice. The primary endpoint was PFS, which was higher in the sacituzumab govitecan arm. OS is immature. The PFS difference is just under 2 months. Curiously, the median duration of response in responders is longer, 12 by 7.2 months. He will be very disappointed, however, that he was followed shortly thereafter by Rebecca Dent from Singapore, LBA21, first-line datopotamab deruxtecan in triple-needle breast cancer women, again, compared with chemotherapy, dealer's choice, same collection of drugs, and they demonstrated that OS was significantly better, with about a 5-month difference in both OS and progression-free survival. So Rebecca is the winner there. And then I just want to finish very quickly on a very happy trial that I don't have a problem with. So LBA12, Fedro Piccatori from Milan presented the 5-year follow-up results from the positive trial, which is pregnancy outcome and safety of interrupting therapy for women with endocrine responsive breast cancer. So what they did was they took women who were on adjuvant endocrine therapy, and this was mostly embedded within 2 cohorts, so positive and soft text. And if you pause your endocrine therapy to get pregnant, not only do many women get pregnant, the vast 69% of those that wanted to get pregnant or paused their thing and wanted to get pregnant had a baby, which is exciting. Some had more than one. And there is no difference in breast cancer events or in OS. Now, we're only at 5 years, but that's as good as it's going to be. So most women went back on the endocrine therapy and had no further problems. Kind of makes sense biologically. Pregnancy is where our bodies are designed to be. It's a happy kind of balance in hormones. That's not a mega statement. That just is what it is. So I'm excited by that. And I have been telling my women for a while, it's safe to pause your endocrine therapy, try and get pregnant, have a baby, then jump back on it when you've finished.
Now, I reckon that was one of the most important findings from the whole conference, actually, Kate, because that's going to make a really big difference to people who are in that situation. And obviously, younger people with hormonally sensitive breast cancer are a population of high need, and having kids is really important to a whole lot of people. And understanding that it's not going to increase their risk is really meaningful. So, big ups to the investigators for doing that particular study, which is going to be really impactful to a lot of people and lead to a lot of happiness, I hope, in time to come.
Yeah, no, I'm absolutely delighted.
I agree, Chris. And so the mantra for a long time has been to avoid.
Yeah, absolutely. Avoid everything. Avoid HRT, avoid pregnancy, avoid breastfeeding.
That's right. So this is part of the accumulating evidence. So can we now put that controversy to bed? Do you think that it's answered now, Kate?
Oh, look, I think I will. Now, that's my personal biases as well. I like Chris, happy events, pregnancy amongst cancer. It's lovely. But I think the other part of hormone manipulation is we spend a lot of time, particularly with low-risk women, talking about a therapy or a behavior, if it's avoiding pregnancy. We talk about therapies which have a 1 to 2% survival difference and ruin women's lives. And women come to me often as a second or a third opinion, begging for permission to stop. And when they see the absolute difference in the two large cohorts of women, they're like, "Oh, why did no one put it this simply before?" And then in terms of pregnancy, we've never actually had any evidence that it increased the chance of women doing badly. We just thought it might, and we have ruined lives on our gut instincts that were wrong.
Yeah, it's been based on the precautionary principle, hasn't it, that you don't want to expose people to a risk that may worsen their cancer, and the fact that you consider that cancer is the only risk that people should be concerned about. And I understand why people have made that recommendation, because it seems to have made sense, but it's great to have the data which demonstrates that it's just dogma that we don't need to adhere to.
Great. And this sort of segues into what was also one of the most publicised abstracts in the meeting. Certainly in Australia, got a lot of publicity, and that was the work done by Shireen Loy and the team at Peter Mac, published in Nature, showing that a cycle of pregnancy, breastfeeding and breast recovery induced an accumulation of CD8 T cells within human normal breast tissue. It doesn't have any immediate clinical implications, but it may explain why there's a protective effect to breastfeeding. These T cells may act as kind of immune modulating cells that can help stop the development of precancerous lesions into cancers, and will open up a whole lot of other lines of research on this sort of T cell protection. So,
yeah, I think that's a really interesting finding. I hadn't actually seen that one at the meeting, Craig, but CD8 tumour infiltration in colorectal cancer was really strongly associated with good outcomes from the French group who looked at that. And also in melanoma, it seems that CD8 tumour infiltration seems to be more important than PD-1 or PD-L1 scoring, for example. So the presence of those activated cytotoxic T cells within a tumour seems to be strongly prognostic and predictive of response to therapy. So understanding mechanistically how you can induce that CD8 infiltration in normal healthy tissue is great new information to have.
Exactly. So, Kate, of all those, you bagged some of those abstracts, but of all those that you presented, and let's just forget about costs or listings, but of all those, which do you think is the practice changing? Is it those?
I think I am going to put my money, apart from the positive trial, of course, on datopotamab. They've got to think of a better name. Datopotamab deruxtecan, Dato-DXd, the TROPION-Breast02 trial. The median overall survival for women with metastatic triple-negative breast cancer of 23 months is huge. Metastatic triple-negative breast cancer has a survival similar to pancreatic cancer.
If the agent sounds like a large water-dwelling animal.
Yeah, yes. I do hope it gets a sexier name somewhere along the line, but that's where we are.
Like a Flight of the Conchords song.
And the deaths and Flight of the Conchords, for those who don't know, is a comedy show from New Zealand. It's pretty funny.
It's actually filmed in New York.
Was it?
Yes. Yeah.
Wow, the Kiwis.
So I went to school with Brett, so yeah.
Yeah, wow.
I'm producer's fangirling.
It's business time. And what about the Destiny abstracts, Kate?
Women who have neoadjuvant anti-HER2 therapies for breast cancer neoadjuvantly who do not have a pathological complete response still have a very, very, very good outcome. That's what Chris was talking about before. The Catherine trial, which was published some time ago, has now pushed most of us into, rather than completing 12 months of anti-HER2 therapy and knowing that most women are going to be fine, pushing all women onto trastuzumab emtansine, which is not toxic, for 14 further cycles, because that's what the trial said. Trastuzumab deruxtecan is another step up toxicity-wise and several steps up price-wise, and we're chasing an absolute delta that is getting smaller and smaller. So my concern, I know you said I wasn't allowed to talk about money and things. I think you have to. Money, tox, etc. I'm just not there. And I do worry about, without an OS, what happens to those women that do relapse? Have we changed the natural history of their cancer? Is it going to not respond to anything else? Have we, what have we done? I have worries.
Fantastic.
I will be alone in my worries. Everybody else will be doing it tomorrow because that's how breast cancer is.
Fantastic. Chris, do you want to do something? I'm just wildly guessing that you might want to cover some of the GI abstracts.
Yeah, nah. I'm going to do some melanoma, Craig, just to mix it up.
Oh, okay.
The endpoint thing is a good segue into the 9-year overall survival data of Nivo versus Ipi in resected stage 3 melanoma. So just to recap briefly, until now, the only positive survival data we've got in resected stage 3 melanoma is Combi-AD, which was adjuvant dabrafenib and trametinib in BRAF mutant melanoma. Only positive survival data. So the EORTC pembrolizumab versus placebo study had DFS positive, OS not reported. And Nivo versus Ipi-10, which is a study, had DFS but OS not reported because immature data and adjuvant population doing quite well. To get to a median takes a long time. So this is the 9-year survival data of Nivo versus Ipi at 10 mg per kg. So now we had minimum follow-up of 107 months, 9 years. Wow, it's a long time. So that's 2006.
Trying to do my 12 divide by 12.
Yeah, 9 years. And so this data was first presented in 2016, and many people have been prescribing nivolumab in stage 3 for quite some time. It's only just been funded in New Zealand, an adjuvant PD-1 inhibitor in stage 3 melanoma for resected disease. I know Australia's been doing it for a lot longer. We know the recurrence-free survival had a hazard ratio of 0.76, which for adjuvant's okay. But with PD-1 inhibitors, the question has always been adjuvant versus at relapse, given that we can cure 20 to 30% of people at relapse. Distant metastasis-free survival, 0.81 hazard ratio with a confidence interval touching 1. But here's the kicker. Overall survival, hazard ratio 0.88, confidence interval 0.69 to 1.11. Overall survival not positive. So yes, a trend towards significance. Bing. Numerically superior. OS 69% versus 65%, which is a 4% difference. And melanoma-specific survival has ratio of 0.87. Again, confidence interval crosses 1, and not positive. The post-protocol therapy is important to note as well. So this was done in 2016, where not everyone was getting access to PD-1 at relapse. But what it's showing is that 37% of people got access to Nivo in the in one arm and 22% in the other. So it's relatively low, 20 to 30% of people getting access to post-protocol therapy. So you're not getting that contamination still in the post-protocol therapy, but people are still not getting cured. And so I think this actually says that resected stage 3 disease, you really have to think very hard and they'd be very high risk before you'd recommend that therapy, because 5% of people get long-term disabling toxicities from PD-1. So those of us who held back a little bit can feel a little bit sanctimonious right now about that data. The landscape's changed quite a bit in that time, though, and now you've got Nadina, which is 6 weeks of Ipi-Nivo, and SWOG 1801, which is 3 cycles of neoadjuvant Pembro followed by Pembro for up to a year afterwards, which both showed improvements in event-free survival at a year, quite good jumps, 20 to 30% jumps in survival for macroscopic disease. So they've become the standard in Australia for sure, and about to become the standard in New Zealand. So for me, this group of patients who have resected and transit Mets, or who have the lymph node surprise at sentinel lymph node biopsy but no macroscopic disease, we don't have data for anything except for TKI to prove overall survival, and the benefit in terms of absolute numbers, clinically meaningful, statistically non-significant, is really quite small, and probably about the same as the lifelong disabling toxicity. So some people may say lifelong disabling toxicities are the same, are outweighed by survival. It's possible, but that'd be pretty optimistic. The other study I wanted to mention, which I do think is practice changing, is the Matterhorn study. So Matterhorn is the study of perioperative FLOT with or without durvalumab in resectable gastric cancer. This is an important study because back when I was a trainee, we had surgery versus perioperative ECF, the MAGIC study. Then you had FLOT versus ECF, and FLOT came out better. And then you had the study of the ESOPEC study in esophageal, which was cross versus preoperative FLOT, which was, overall pretty similar, to be fair. It was mostly ECF, though, rather than FLOT. And so this is the FLOT with or without durvalumab in the preoperative setting. Now, we did have PathCR data previously from the study showing that PathCR was better with the addition of durvalumab. But PathCR is not a validated endpoint for overall survival in perioperative gastric cancer, so we weren't quite certain if that was necessarily going to translate. But what this does show us is that overall survival was improved with a hazard ratio of 0.78. 95% confidence interval did not include 1. Event-free survival was as reported. PathCR correlated with improved outcomes with good hazard ratio, and the better the Path response you got, the better your outcome was, but that's prognostic, not predictive. And the incremental survival gain was almost 7%. And bearing in mind that ECF versus surgery is plus 13%, FLOT versus ECF is about another 10%, and there's about another 7% on top of that. So this is a clinically meaningful and statistically significant improvement in overall survival in a curative intent population where durvalumab is not a survival improver in the salvage setting. So, drumroll, I think this represents a new standard of care. And the key issue there is going to be the cost of this medicine coming into the clinic. So I think that's an important improvement, and that I think will rightly change practice as of now. So get onto socials and disagree with me if you like. Love to hear your views if you have a different take on that. The other big news that came out was in the circulating tumour DNA studies. Now, there were two really important but quite contrasting studies, and that was the ctDNA study in adjuvant colon cancer and the ctDNA study in adjuvant bladder cancer. I'm going to discuss these together. First of all, I want to congratulate the researchers on this, particularly in the colorectal study, which was led by Professor Jeannie T, who's a Kiwi, in case anyone who listened to the show didn't know that. Jeannie, Kiwi. And Peter Gibbs at Melbourne, obviously, and a lot of the AGITG researchers as well, familiar names to many listeners in this podcast. So a really good effort. 1,000 people were recruited to that study over time. So a huge effort to pull that off, and a lot of respect to the investigators for their efforts. 1,000 patients in Dynamic 3, and the randomization was standard clinical pathologic adjuvant therapy versus ctDNA guided strategy. If you were ctDNA positive, you would get oxaliplatin-based chemotherapy usually for 6 months, and if you were ctDNA negative, you would have shorter duration, so 3 months, or no adjuvant or fluoropyrimidine alone. And the primary endpoint was DFS, and secondaries was overall survival. The results showed that the ctDNA guided strategy did not improve disease-free survival. And if anything, the DFS was slightly worse by 2% than the standard of care arm, which did not consider ctDNA as a strategy, and OS was immature. I was at a conference recently where ctDNA was held up by one researcher as being a fait accompli. Why do we need to do randomized phase 3 trials incorporating ctDNA into our decision-making structures? It was obvious. Phase 3 trials are expensive and unnecessary, and we should just get on with it. And doctors who say that's not the case, well, they're just gatekeeping. So I think the study published 2 weeks later really knocks that out of the park and shows that actually in this particular situation, we don't have a good escalation or de-escalation strategy, that the ctDNA is prognostic, but it's not predictive, and therefore it can't change your clinical management. And if you did use it, you would threaten numerically at least overall survival. The other ctDNA study that was of note at ESMO was the adjuvant atezolizumab in muscle-invasive bladder cancer study by Tom Poles and colleagues. And what this study did was, it was actually smaller than the Dynamic 3 study, but randomized phase 3 double-blind clinical trial, where those who were ctDNA positive after resection of their muscle-invasive bladder cancer were randomized 2-to-1 to receive atezolizumab or placebo for up to a year. So this was an important study which did have an escalation. Of course, this is in the context of prior adjuvant immune therapy studies in bladder cancer, maybe impacting on DFS but not impacting on OS. OS hadn't been proven before in bladder cancers for immune therapies, and in adjuvant it remains controversial as to whether any therapy is particularly helpful. The primary endpoint in the IMvigor 011 study, which was the ctDNA study, had a hazard ratio of 0.64 for DFS and a hazard ratio of 0.59 for overall survival. So the overall survival with ctDNA-guided atezolizumab was 32.8 months compared to 21.1 months. So it's a whopping 11-month improvement in overall survival, which was clinically significant, which was statistically significant and clinically meaningful. I don't think anyone would debate an 11-month improvement in overall survival as being clinically not meaningful, because it is, and that hazard ratio of 0.59 is strong as well. The authors also reported, get ready with your Bing, Craig, toxicity was manageable, with grade 3-4 adverse events of 28% in the atezolizumab arm versus 22% in the placebo arm. So this is the first ctDNA-triggered adjuvant study to show both DFS and OS benefit, and it validates MRD, minimal residual disease, as a predictive biomarker and supports immunotherapy escalation for ctDNA positive patients. So now the problems are going to be getting your ctDNA done in a timely fashion, particularly in a relevant turnaround time for patients, having the right assay to detect minimal residual disease, and then getting people onto this therapy as well. So I think those studies are practice-changing their team. I think DFLOT, new standard of care. I think adjuvant atezolizumab in ctDNA-positive bladder cancer, new standard of care. And I think ctDNA in stage 3 colon cancer, prognostic, should not guide your therapy at this stage.
Yeah.
So it's interesting to compare and contrast those two studies and the results, because I'm glad you brought up the InVigor study. I was going to mention that amongst the genitourinary tract. But so there you have clearly ctDNA positive patients, you escalate the treatment with an effective treatment, the checkpoint inhibitor, and you see a benefit. The same strategy in the dynamic 3 didn't work. There's that sort of confusing result in the dynamic 3 where the de-escalation, it's probably the same, but we're not entirely comfortable with that. So what are your thoughts? Do you think that de-escalation strategy for the negative patients in the stage 3s works, or?
Yeah, look, I think the problem is that actually the problem for the dynamic investigators was that the de-escalation versus escalation strategies just aren't that different, because 3 months versus 6 months of FP-OX is the same. So it's not a real escalation or de-escalation strategy. That's not the fault of the investigators. It's not the fault of the technology. It's the fact that we don't have a really good de-escalation position in colon cancer, which is really different to InVigor, whereby you do have a good escalation, which is PD-1 in that situation. We just don't have that in colon. And so that's, I think, the reason probably why it failed, why it didn't reach statistical significance, and why there was a numerically worse OS in the ctDNA-guided arm.
Yeah, good.
I wanted to congratulate the InVigor team for thinking things through radically and taking a risk, because it must have been tempting to do another stock standard adjuvant IO versus nothing trial. And this is really helpful. So in that arm that was ctDNA informed, half of patients avoided adjuvant therapy.
Yeah.
You know, and those people did very, very well, you know, that they aren't relapsing. So that's so much useful information in one trial, because it's been logically thought through and planned. And I wanted to congratulate them for doing that and for taking what must have been a complicated risk at the time. Really, really excited about it.
Yeah, it provides a blueprint too, doesn't it? Where you know you've got a therapy which is a potential marginal benefit in the adjuvant setting to try and identify who might actually benefit from it. So I think it's a great blueprint for others to follow. Unfortunately for colon, we just don't have that good thing. But I think if we do get another drug or another biomarker or something like that, it might actually help be another stratification factor for that, and it may well get rerun again.
Yeah, we had a session at NZSO where I was allowed to give a list of things that I'd like off the scientists, and one of them was some more drugs in colon cancer so we could rescue the patients who don't respond to 5-FU or not cellophane. In the adjuvant setting, we've got other drugs. Yes, yeah.
Seems a long time since we've had a good adjuvant study in colon cancer. What do we got?
That's
We've got
right.
aspirin and PIC3, we've got exercise, and we've got oxaliplatin.
Pregnant pause.
Which is perfectly safe in breast cancer survivors.
As we reflected. Chris, did you have anything else you wanted?
No, they were the big four I wanted to cover off there, Craig. They were the headline winners there.
Yeah, great. I think the dynamic 3 was the most controversial, and, I think it's going to lead to quite a lot more discussion, I would say. Well, that's been fantastic first part. We'll be back next week for part 2 because there's some great information there. So, Dankeschön, everybody. Auf Wiedersehen. Tschüss.
Bitte, bitte, schön, schön, sehr schön. That's all my German used up. Apart from, kommst du mit?
Oh,
I've only got German swear words. That's all I've got.
That sounds bad, Kate. Can you say that again and explain it?
Kommst du mit? It means come with me.
Right.
Which you really mean join me from the waiting room to the consultation room, because that's a phrase that we use as an oncologist, right?
Yes.
I can't think of any other circumstances where you would need that phrase.
Interesting. You never know with Kate, though, do you? She could have picked that up in a German nightclub.
I did my elective in India with a whole lot of Germans and may have learnt some things. Yeah.
Oh, dear.
Well, you're a lifelong learner, though, Kate. That's one of the things I love about you.
Well, on that note, thank you to all the listeners. Thank you for all the feedback. I hope you enjoyed that episode, and we'll be back with part 2 next week. So thanks, everyone. See you soon.
Mate wa.
Shout out.
Thank you for tuning in to the Oncology Journal Club podcast, proudly brought to you by the Oncology Podcast, part of the Oncology Network. For healthcare professionals seeking regular news updates and insightful discussions, we invite you to join our community at oncologynetwork.com.au. Your free registration includes a complimentary subscription to our weekly publication, the Oncology Newsletter, a valuable resource to stay updated on the latest advancements in the field. We value your input and welcome your feedback and paper recommendations via our social media channels, email and website. Your insights help shape the conversation and drive the direction of future episodes. This is Rachel Babin signing off for the Oncology Journal Club podcast.